My next guests have firsthand knowledge of our urban and rural health infrastructure needs, as well as insights on what exactly is needed to support research efforts. Dr. Mary Klotman is the Dean and Vice Chancellor for Health Affairs at Duke University School of Medicine. Love Duke. And Dr. Kirk Calhoun is the President of the University of Texas Health Science Center at Tyler. Go East Texas. So it's great to have you both on. And let me just start with you, Mary. I think that, one of the things, and I know you have done a lot in the research field. I know that you're want to see more done in critical research, and you worked with a hero of mine, Robert Gallo, who was very active in HIV/AIDS research. I'm just interested in understanding, what does as we think about viruses, as we think things out there, what are the building blocks like? What are the missing parts of the scaffolding and infrastructure we need to have in tackling not only COVID or SARS-CoV-2, which we have right now, but also, an oncoming set of viruses, right? For you, this has been a long story.
Well, the good news is a lot of the building blocks are there in terms of the work that academic institutions and medical schools have been doing for years. And with great partnerships such as the NIH, building that army of scientists that are skilled and ready to take on a new challenge, but also the infrastructure. We have a biosafety containment lab that came out of 9/11. But that structure, which was a partnership with NIH, has allowed us to rapidly pivot to start working with this new pathogen that really required that kind of containment. So I think some of the infrastructure is there. I think where we really need to build is how do we coordinate our efforts? We need to be efficient. When you have something like this pandemic moving as rapidly as it has, let's talk about clinical trials. We probably could have had many of the answers already if we really were organized nationally to address in rigorous, randomized controlled trials all of these questions around which therapeutics work, which don't. So I would say, how we organize, particularly across institutions, is something that we need to work on. But I think some of the building blocks have been there because of these great partnerships between academic medical schools and our funding agencies. So I think there's good news and then some challenges there.
Well, before I leave you on the issue of clinical trials, which really interests me because you have to work across different ethnic groups, you have to look across different ages, you have to look at lots of different factors in trying to deal with that out there. Who can play that role? Who can meet the challenge that you just said we need to meet? Who's the right player in moving that forward?
Well, I think the academic medical schools are the right players because actually there's a lot of skill that has to be acquired in terms of how you plan these trials. They have to be rigorous. They have to be randomized. They have to control for the right populations. It does no good to test an intervention in a population that's not the population being affected or disproportionately affected. So I think that the academic medical centers can. I think it's how you coordinate it so that everybody's, really testing and asking questions that build on each other rather than being redundant. I think we have shown remarkable ability to get studies up in record time compared to the past, which used to take anywhere from 8 to 12 months. We were able to stand up some clinical trials in 6 weeks. But it's really the coordination, having a national network. I grew up around AIDS. And, AIDS was a remarkable story and a good story. But what allowed that field to move forward was a coordinated effort across medical schools dealing with large populations of HIV-infected individuals so that we could rigorously test compound after compound. And again, I give a lot of credit to the NIH as being the organizing body around that. So again, I think it's a partnership.
I'm fascinated by it. Another time we'll have to talk about your work with Dr. Gallo and all that. I'm fascinated by that time period. Dr. Calhoun, I know one of your interests has been focused on rural health. I have to tell you, I had Dr. Redfield of the CDC on here, and to say that he was near a moment of volcanic eruption would be an understatement when we were talking, in his view, of how we have underinvested in public infrastructure, or public health infrastructure, how we have underinvested in underattended rural health. And so this is a big priority. And this is a guy with power, with resources, who sees this. And I'm interested, in how you see it and what can be done to move the needle when it comes to getting better public health infrastructure broadly in the nation, but also dealing with the rural health side.
Well, I'm certainly happy to hear that he erupted. That
right
issue,
near,
came
yeah.
up. Because we think about it a lot. When you look at the history of our institution, and we're here in Northeast Texas, it's predominantly rural. It's we have a population of about 2 million people in an area the size of West Virginia. And we have served this area and started off actually as the state's tuberculosis sanitarium. And if you look at the history of TB, for example, when we have outbreaks, then there's major investment in the public health infrastructure to be able to deal with that particular kind of infection. But as soon as we tend to bring it back under control, then the funding goes away and the interest dissipates until it comes back again and we have crisis once more. We have, as the university, early on in this, we provided a good deal of our own resources to helping back up local rural health departments that did not have the staffing to do contact tracing and some of the other routine public health measures. We were able to step up and help provide them some of that backup through our School of Public Health. But it's really dawned upon me that we can do better and ensure that we have a much stronger local public health infrastructure, certainly in urban areas, but all across rural America, so that we can deal with these kinds of emergencies more appropriately.
Well, let me ask you, one of the things I think it would be useful for our audience to hear, what I imagine is a significant lay audience on these issues, is we talk a lot about these different units. Some are academic medical centers, some are, as you're in, health science centers, some are hospitals. Would you mind doing us a favor and just helping us to understand both your network, but how, who's doing the research, the training, and these elements, and how do they sit next to hospitals? And I think it would be a useful description for our audience.
So I can start off.
Okay.
Duke is probably one of the more sort of, I would say, classic academic health systems where you have a medical school tightly aligned and integrated with a health system being 3 hospitals and dozens of clinics.
Right.
So what happens on a daily basis is you have integration of your core mission. So you have trainees and students. They're in the medical school, but a lot of their work is in the health system. You have research that spans the spectrum of basic science, which occurs in labs, to clinical research, which occurs side by side in our health system. You have clinical care, which is delivered by a lot of our faculty that are also teaching our students. So on a daily basis, you have this rich integration of missions that allows us to really leverage that partnership between a health delivery system and an academic system. And my aspirational dream is when that works seamlessly, so that we can really learn every day from a patient that walks in for care. We're also learning how to provide better care and teaching at the same time. And that's really what an academic medical center does on a daily basis.
Dr. Calhoun, your thoughts?
Yeah, sure. It makes me think back to when I was a young medical student. I would talk to my faculty about what is life as an academic physician in an academic medical center or health science center. Those are terms that are frequently mixed together. And we used to refer to it as three-legged stool, that academic medicine had one leg, which was research and the discovery of new knowledge, new treatments. The second leg is education, and educate the next generation of healthcare providers, whether it's in a medical school, a nurse school, pharmacy school, so forth. The third leg of the stool is our clinical care delivery, taking care of patients, because you can't educate the next generation of healthcare providers without a robust clinical support structure behind you to allow you to do that, and that's taking care of patients. And personally, I added actually a fourth leg, which is community and public health, which is emerging now as a critical element into how we provide a safe and healthy environment for our citizens.
Appreciate that. And I'm interested in also the interaction with the private sector out there. We have a lot of focus on Operation Warp Speed. What is the government doing? Who's the government funding? But so many of your centers are tied into clinical trials, research-based. How does that interaction occur? And are these pharmaceutical firms good partners in this process? Dr. Klotman.
So these partnerships are critical. And again, going back to ACE,
right.
The reason that worked so beautifully was the partnership was between academic health systems, pharmaceutical industry, and sponsored research organizations like NIH. So the pharmaceutical industry is very much a part of what we do on a daily basis. They're good partners. We have a clinical research institute that leads some of the largest impactful clinical trials in the world. I think when you have that really good working relationship so that there's rigor and there's controls and there's really distance in terms of lack of conflict, personal conflicts that might come up with managing research, that's a really, really important partnership. And so I would say they are very much a part of certainly the work that we do here at Duke, and those partnerships are critical for certainly something like this pandemic. New pathogen, need to develop new drugs, need to do the rigorous clinical trials to test those drugs, and need sponsored research to make that happen.
Dr. Calhoun, I'd love to get your take on that, and then I'm going to kind of commit a science faux pas here and just ask you, because we've got a question from our audience we want to bring in. But the science faux pas, because right now in Washington, everybody wants this solved. We want to hear, is convalescent plasma going to work? Are we going out too early? There's sort of a debate on whether we need to rush forward or whether we need to let science play out as science is and kind of educate the public that that's there. So I just want to admit it's out there. But I just want to say, do you think we're going to get a vaccine on this? What does your gut tell you, if you're allowed to say that, which you might not be?
Well,
Dr. Calhoun?
Going with your gut is sometimes a very good thing to do. I want to remind everyone that a little more than 7 months ago, COVID-19 was not part of our regular discussion set, so to speak. We have moved remarkably fast. And with the care that you need to exercise, because if you do move too quickly, mistakes get made and patients suffer as a result. So that's the balance, right? How quickly can you go and make sure that you do it correctly and you protect patients? Because if you look at the history of medicine, there have been times in our disease management history where we have gone a little bit too fast and patients have suffered as a result. When this all started, almost immediately at our center, and I'm sure at Duke and all around, people started investigating and forming partnerships, private industry with other academic medical centers, with NIH. First of all, looking at diagnostics. How can we diagnose the disease better? How can we come up with new and better tests? I think we're going to be hearing about saliva tests and other things coming out very, very soon that's going to make it easier and less complex for us to do testing. People started investigating therapeutics. How do you treat this? And we've learned things from how you should be positioning these patients in the hospital bed and how you manage the ventilators, as well as therapeutics like remdesivir and steroids and convalescent plasma. We're part of a large, carefully designed NIH study looking at convalescent plasma, because there are a lot of questions that are still out there as to how do you use it, how well does it really work, what populations do you use it in, and what dosages do you use. Do neutralizing antibodies have to be present in the convalescent plasma? There are many, many questions that are still out there. And now we're actually formulating the studies that can begin to answer those questions well. And then finally, with regard to vaccine, our virologists everybody was racing, quite honestly, trying to identify a vaccine. The vaccines can be challenging. We've talked about HIV a couple of times here. We still don't have a prime time vaccine for HIV yet, and it's not for a lack of trying. The effort has been enormous. So these are complex issues. I'm hopeful, very hopeful, in fact, that we'll have a vaccine. Developing that vaccine, manufacturing that vaccine in a safe manner, and distributing the vaccine and implementing a vaccination program that will touch a major portion of the population. That's going to be our challenge over the next year or so.
Thank you. And I want to just say for the audience, I really appreciate the cautionary tale that you added to that because, I'm saying, hey, let's shoot from the gut. But I mean, we really shouldn't be shooting from the gut. We really should be looking at how science evolves. Some of the time curves can be bent, but not on safety and efficacy.
If you go back and look at it, the first batches of polio vaccine that were produced, and that's a massive effort with a lot of government support. But there were errors made, and patients suffered as a result. There are examples in our medical history where we've moved too quickly, failed to adhere to our scientific method, and as a result, those mistakes were made. And so we just need to exercise that appropriate care.
I think it's important to remember that for a vaccine, the safety bar is really high because you're giving it to people that do not have an illness. And that's very different from developing a therapeutic when a person is sick and they have very few options. So the safety issue cannot be overstated, and science really has to drive this.
Well, I want to thank you both for joining us today. Fascinating conversation, and I would like to have taken it a lot longer. We're out of time. We're going to talk to two other of your colleagues shortly, but Mary Klotman, Dean and Vice Chancellor for Health Affairs at Duke University School of Medicine, Kirk Calhoun, the President of the University of Texas Health Science at Tyler, Texas. I have a lot of relatives that are probably patients of yours. So thank you both so much for joining me today.
Thank you for having me.
Thank you.